Welcome. Today, we're diving into a common yet often misunderstood condition affecting the urinary system, urethral stricture. We'll explore what it is, what causes it, how it's diagnosed, and the various treatment options available. Understanding this condition is crucial for early detection and effective management, so let's get started. Urethral strictures occur when scar tissue forms within the urethra, the tube that carries urine from the bladder to the outside of the body. The most common cause is injury or trauma to the urethra, such as from a pelvic fracture, straddle injury, or instrumentation like catheterization. Infections, especially sexually transmitted infections like gonorrhea and chlamydia, can also lead to inflammation and subsequent scarring. Less common causes include prior urethral surgery, radiation therapy for prostate cancer, or even congenital abnormalities present at birth. In some cases, the cause remains unknown, referred to as idiopathic urethral stricture. The pathophysiology of a urethral stricture revolves around the healing process following injury or inflammation. Initially, inflammation damages the urethral lining, called the urothelium. As the body attempts to repair the damage, fibroblasts lay down collagen, forming scar tissue. Unlike normal tissue, scar tissue is inflexible and lacks elasticity. This scar tissue gradually narrows the urethral lumen, obstructing the flow of urine. This obstruction leads to increased pressure within the bladder, potentially damaging the bladder muscle and even affecting the kidneys over time. The severity of the stricture dictates the degree of obstruction and the resultant symptoms. Urethral strictures are more common in men and women due to the longer length of the male urethra. The exact prevalence is difficult to determine, as many men may not seek treatment for mild symptoms. Studies suggest that the incidence increases with age. Factors like a history of sexually transmitted infections, urethral catheterization, or pelvic trauma significantly increase the risk of developing a stricture. Specific populations, such as those with certain genetic predispositions or those undergoing certain medical procedures, may also be at higher risk. The symptoms of urethral stricture can vary depending on the severity and location of the narrowing. Common symptoms include a weak or slow urinary stream, straining to urinate, incomplete bladder emptying, frequent urination, and urgency. Some individuals may experience pain or burning during urination, or even blood in the urine or semen. Urethral strictures can also contribute to recurrent urinary tract infections due to the incomplete emptying of the bladder. In severe cases, complete urinary retention may occur, requiring immediate medical intervention. Diagnosing urethral stricture involves a thorough medical history and physical examination. A urine flow rate test, or uroflowmetry, measures the speed and volume of urine flow, often indicating an obstruction. A post-void residual volume measurement checks how much urine remains in the bladder after urination. Urethroscopy, where a small camera is inserted into the urethra, allows direct visualization of the stricture. A retrograde urethrogram, using X-rays and contrast dye, can delineate the length and location of the stricture. In some cases, avoiding cystourethrogram (CUGA) may be performed to visualize the bladder and urethra during urination. Urethral strictures can be classified based on several factors, including their location, length, and severity. Anatomically, they can occur in the bulbar urethra, the penile urethra, or the membranous urethra. Strictures can also be classified by their length, with short strictures being less than 2 cm and long strictures exceeding that length. Furthermore, they can be graded based on their severity, ranging from mild narrowing with minimal symptoms to complete obstruction. These classifications help guide treatment decisions and predict outcomes. Treatment for urethral stricture aims to relieve obstruction and restore normal urinary function. Options range from minimally invasive procedures to surgical reconstruction. Dilation involves stretching the urethra with progressively larger instruments. Urethrotomy involves cutting the stricture with a blade or laser passed through a scope. These methods can provide temporary relief, but strictures often recur. Urethroplasty, surgical reconstruction of the urethra, offers a more durable solution, often involving the removal of the scarred tissue and the reconstruction of the urethra using tissue grafts. The specific approach depends on the location, length, and severity of the stricture, as well as the patient's overall health. Regular follow-up is essential to monitor for recurrence. Preventing urethral strictures focuses on minimizing risk factors. Practicing safe sex can reduce the risk of sexually transmitted infections. Using proper technique during urethral catheterization can minimize trauma. Prompt treatment of urinary tract infections can also help prevent complications. In individuals with a history of pelvic trauma, careful monitoring and appropriate management are crucial. Avoiding self-instrumentation or unnecessary urethral procedures is also recommended. The prognosis for urethral stricture depends on the chosen treatment method and the characteristics of the stricture. While dilation and urethrotomy offer less durable results, urethroplasty provides a higher success rate for long-term relief. Recent research focuses on improving surgical techniques, such as incorporating tissue engineering and regenerative medicine approaches to enhance healing and reduce recurrence rates. Researchers are also investigating novel drug therapies to prevent scar tissue formation after urethral injury. Furthermore, advancements in minimally invasive surgical techniques offer the potential for less pain and faster recovery times. Continued research promises to improve the lives of individuals affected by urethral stricture.